The broadcast is now starting. All attendees are in listen-only mode.
Cecilia, you may start.
Good morning, good afternoon, everyone. My name is Cecilia Scarponi, EMEA Clinical Liaison in Ortho, and I have the pleasure to introduce you, to welcome you at this webinar. Good afternoon, everyone. My name is Cecilia Scarponi, EMEA Clinical Liaison in Ortho, and I have the pleasure to introduce you, to welcome you at this webinar. So thank you everyone for joining us this webinar, and thank you Dr. Jasper Boddinghaus for your time today. Dr. Boddinghaus, resident in cardiology at University Hospital Basel, Switzerland, will discuss how to clinically validate the novel VITROS HS cardiac troponin assay and to derive and validate an assay-specific 0-1 hour algorithm according to the European Society of Cardiology recommendations, and to overcoming challenges in validating and implementing such algorithm. He will also share with us the 2020 new ESC recommendation. And with this, please welcome with me Dr. Jasper Boddinghaus. Please, the floor is yours.
A very kind introduction. So, ladies and gentlemen, dear colleagues, it's my really great pleasure to give you this webinar on the clinical use of high sensitivity cardiac troponin and the clinical use and implementation of the ESC 0-1 hour algorithms. So these are my disclosures. My research that I'm doing here in Basel, Switzerland is mainly funded by the Swiss National Science Foundation and the Swiss Heart Foundation, but I do also receive research and travel as well as consulting support from diagnostic companies. My most important disclosure is actually shown on this slide, as it shows the team of the Cardiovascular Research Institute in Basel, where I work as a clinical research fellow under the supervision of Professor Dr. Christian Müller, who is an expert in the field of cardiovascular biomarkers. So today in this webinar, I would like to talk about the use of high sensitivity cardiac troponin for the early diagnosis of an acute myocardial infarction in general. I will then focus on the rapid rule-in and rule-out algorithms that are recommended by the European Society of Cardiology. I will give some examples regarding the medical value of these rapid rule-in and rule-out algorithms. And finally, I will present you the exciting data that we generated in cooperation with Ortho Clinical Diagnostics, and where we validated a novel high sensitivity assay and derived and validated a 1 hour algorithm. So you all know that an acute myocardial infarction is a harmful and acute condition. We know that about 10% of patients presenting to emergency departments worldwide do have symptoms suggestive of an acute myocardial infarction, with the lead symptom, which is acute chest pain. So an acute myocardial infarction, therefore, is a common phenomenon, and it is an acute life-threatening condition. Its rapid diagnosis and treatment is therefore critical because time is muscle, and there are some effective strategies and treatments available. For example, a rhythm monitoring of our patients, the initiation of a dual antiplatelet therapy, and of course, a percutaneous coronary intervention. But on the other hand, it's also very important that we can rapidly rule out an acute myocardial infarction in the emergency department. And this is of major medical and economic importance because it is very important to timely detect and treat alternative causes of acute chest pain. And there's a wide range. And we have to consider that an outpatient management is possible in many of patients presenting with acute chest pain to the emergency department. About 15 to 20 million patients present to the ED in Europe and the United States per year with chest pain. But we know that in these patients, an early triage decision is necessary, and we know that only a minority of these patients then finally have an acute myocardial infarction. An acute MI can be ruled out in the majority of these patients. Indeed, it can be ruled in some of them. And then there are patients with an unclear condition, triaged towards a so-called observed zone, who then need a further diagnostic workup. So how can we make the diagnosis of the presence or absence of an acute myocardial infarction? There are actually 4 different cornerstones. First of all, it's the clinical setting and the clinical symptoms and vital signs of the patient. So for example, the character of the chest pain. Second, it's the 12-lead ECG that should be performed immediately within the first 10 minutes after patient's arrival. And then there is the cardiac biomarker. And here it is recommended that we use and we measure the cardiac troponin concentrations in our patient's blood. And we should do this optimally by using a high sensitivity assay. And troponin concentrations should be measured at presentation and then serially thereafter. By using these diagnostic cornerstones, we then can make a triage decision whether we can rule out an acute myocardial infarction, and most of these patients do have a non-cardiac cause of their chest pain, or if we should have to rule in an acute myocardial infarction, most of these patients do then have an ST or non-ST elevation myocardial infarction, and then we have those patients classified as observed, for example, patients with an unstable angina or another underlying cardiac cause. This is the central illustration of the current ESC 2020 guidelines. However, it is important to remember and to highlight that we should never interpret cardiac troponin concentrations in isolation, but always in conjunction with these 4 diagnostic cornerstones. So I would like to start the presentation with a clinical case, which I think nicely demonstrates the differences between the old-fashioned contemporary and the newer generation sensitive and high sensitivity assays. So in 2009, there was a 45-year-old male patient presenting to the emergency department here in Basel, Switzerland. He had chest pain that started more than 6 hours ago. It persisted for 30 minutes. It was not radiating. The patient was not sweating, and it was the first episode ever. At the time of arrival to the ED, the patient was totally asymptomatic. Regarding risk factors, he was known to be a former smoker with a total of 20 pack years. The blood pressure was quite high, the pulse was regular, and the peripheral oxygen saturation was normal. So we performed an ECG, a 12-lead ECG, and if you are familiar with ECG interpretation, there were no signs of acute ischemia, so no signs of an ST or non-ST elevation myocardial infarction. So what happened, blood was taken, and back then we used a 4th generation troponin T assay with a limit of detection of 0.01 micrograms per liter. So at presentation, the troponin concentration was not even measurable in this patient. And the more conventional cardiac biomarkers, CK and CK-MB, were in the normal range. So back then in 2009, the ESC guidelines recommended to perform a retesting after 6 hours, and still the troponin concentration was not measurable. So what happened? The patient was discharged and he was scheduled for an outpatient stress testing. Unfortunately, the same patient came back 4 days later to our emergency department, again with acute chest pain, and now the pain was radiating in his left arm and back. So again, we performed a 12-lead ECG, And now there were clear signs of an inferior ST elevation myocardial infarction. So we diagnosed a STEMI. The patient was directly transferred to the cath lab where an occluded right coronary artery was found. So now is the question, what about the cardiac troponin concentration at the initial presentation 4 days earlier? So just as a quick reminder, at the initial presentation, all the troponin concentrations were below the limit of detection. Fortunately, we enrolled this patient in our large chest pain trial, and we took blood from this patient serially at presentation 1, 2, 3, and 4 hours. And this allowed us to retrospectively measure cardiac troponin concentrations by using a sensitive and 2 high sensitivity cardiac troponin assays. And what you can see is that by using one of these 3 assays, there were clear elevations in cardiac troponin concentrations within the first 2 hours with a significant dynamic change. So using one of these high sensitive assays 4 days earlier would have led to the diagnosis of a myocardial infarction at the initial presentation. So I think we can learn from this case that sensitive and especially high sensitivity cardiac troponin assays improve the early rule-in of an acute myocardial infarction in the emergency department. So what is known about cardiac troponin in general? It is known and also stated in the current guidelines that cardiac troponin is superior to other cardiac biomarkers such as CK, CKMB, or myoglobin. It is also known and recommended that high sensitivity assays should be used whenever possible because they detect smaller acute myocardial infarctions that may be missed when using a conventional assay, and they detect an acute myocardial infarction much earlier. What do the ESC guidelines say? They say that cardiac troponin is superior. They say that we should use high sensitivity assays. And they say, and this is very important to remember, the cardiac troponin concentrations measured by a high sensitivity assay should always be interpreted as a quantitative parameter. And that means that we should not interpret cardiac troponin as a pregnancy test. It is incorrect to say that a cardiac troponin concentration is negative or positive. We have to remember, the higher the cardiac troponin concentration, the higher the likelihood for an acute myocardial infarction. And this is nicely illustrates by this figure, where you can see plasma troponin concentrations in young and healthy individuals in the normal range. Then we have in the elderly, for example, with many comorbidities, chronically elevated cardiac troponin concentrations. Then we have myocardial injury if the cardiac troponin concentration reaches the 99th centile, and if it is higher than the 99th centile. And then, of course, we have a myocardial infarction, a condition where a lot of troponin is released into the peripheral blood, and then resulting in very high troponin concentrations. So the higher the cardiac troponin concentration, the higher the likelihood for the presence of an acute myocardial infarction. And this is also shown by this slide, where you can see the negative predictive value for the rule out of an acute myocardial infarction and the positive predictive value for the rule in of an acute myocardial infarction. You see here given as an example for the troponin T assay, which has a 99th centile of 14 nanograms per liter. And then you see the wide range of differential diagnosis in patients presenting with acute chest pain to the emergency department. So if we start at the bottom line, we might have healthy individuals, young patients presenting to the ED who have very low cardiac troponin concentrations, for example, 5 nanograms per liter. We know that these patients do have a very high negative predictive value for the rule out of an acute myocardial infarction. Then it's getting a bit more tricky in those patients with concentrations around the 99th centile, and especially in those patients with mild elevations, because these patients might have a small myocardial infarction, they might have pulmonary embolism, they might have shock, they might have a hypertensive crisis, and all of these conditions could result in slight elevations in cardiac troponin concentrations. But finally, again, the message, the higher the cardiac troponin concentration, the higher the positive predictive value for the presence of an acute myocardial infarction. So let's come to the guideline recommendations of the European Society of Cardiology. And these guidelines recommend different rule out and rule in algorithms. If we have a look back into history, it was recommended until since 2011 that the second blood draw should not be performed after 6 hours. This was how we did it before 2011. So patients had to wait for a long time in the emergency department until we were able to rule out an acute myocardial infarction. And this changed with the introduction of the ESC guidelines in 2011, because since then, the so-called 0-3-hour algorithm is recommended for clinical use, which says that we should perform the second blood draw already after 3 hours. And this is the concept of the 3-hour algorithm. It looks quite complicated, but I will try to guide you through this quickly. So we have patients in whom we ruled out a STEMI. So we could apply this algorithm to patients with a suspected non-STE acute coronary syndrome. Then we have those patients with troponin concentrations below the 99 centile, so the upper reference limit of normal. And then we have to differentiate those patients presenting with chest pain that began more than 6 hours ago. If it started like more than 6 hours ago, if the patient is pain-free at arrival, if the Gray score is below 140, if dangerous differential diagnoses are excluded, we can discharge these patients. If the pain started within the last 6 hours, it is recommended to perform a retest after 3 hours. And then we have to see if there is no significant change or if there is a significant change. And if there is, then it indicates the presence of acute myocardial injury, maybe acute myocardial infarction, and then these patients need invasive management. On the other hand, there are two rule-in opportunities. There is the first option, which says that if we have highly abnormal cardiac troponin concentration and a very typical clinical presentation, these patients should be directly ruled in for invasive management, or we have those patients with mild elevations. Again, we should perform a retest after 3 hours, and then we have to see if there is a significant change or if there is no significant change. However, in 2015, the updated version of the guidelines was published, and since then it is recommended that we use the 1-hour algorithms in clinical practice as an alternative to the 3-hour algorithm if a high sensitivity assay is available. And now, like about 10 days ago, the 2020 non-STE-ACS guidelines were published, and now in the current version of the guidelines, there is another alternative to the 1-hour algorithm, which is the so-called 0-2-hour algorithm. And the 0-2-hour algorithm means that we have to perform the second blood draw 2 hours after ED presentation. So what is the concept of the 1-hour algorithm? It's actually quite easy. Again, first of all, we have to rule out the presence of STEMI by a non-diagnostical ECG, and then we should apply the 1-hour algorithm to patients with a suspected non-STEMI. We can rule out patients if they have either a very low baseline concentration of cardiac troponin, but only in those patients with a chest pain onset of more than 3 hours ago, or we can rule out a non-STEMI in those patients with a low baseline concentration and a non-significant 1-hour change. Most of these patients can be treated as outpatients if, of course, other life-threatening disorders are ruled out. On the other hand, the 1-hour algorithm rules in patients if they have either a very high baseline concentration of cardiac troponin or if they have a relevant 1-hour change. Most of these patients then have conditions that need an invasive strategy, such as acute myocardial infarction, myocarditis, or Takotsubo syndrome. And then we have those patients with mild elevations in cardiac troponin concentrations who do not fulfill the rule out or rule in criteria. And these patients have to be are triaged towards observed and then need a further diagnostic workup, for example, by resampling of cardiac troponin at 3 hours, we should perform an echocardiography or, for example, exercise stress testing. And it's important to highlight that the 1-hour algorithm needs assay-specific cutoffs. So once a new assay becomes available, one has to derive and validate assay-specific cutoffs. And here you can see all the different assays, like the orthoclinical VITROS assay, for which a 1-hour algorithm was already derived and validated and recommended in current guidelines. There is huge evidence behind the diagnostic performance of the 1-hour algorithm. So one of our work was a prospective validation of the 1-hour algorithm in more than 4,000 patients. And here we prospectively validated the cutoff specific for the troponin T assay. And what you can see is that about 60% of patients can be ruled out after presenting with acute chest pain to the emergency department with a negative predictive value of 99.8%. So it's a very safe approach. On the other side, we can rule in 18% of patients with a positive predictive value for a non-STEMI of 75%. And then we have 1/4 of patients triaged towards observe, who then need a further diagnostic workup. It's important to mention that this very high safety was demonstrated in several different cohort studies, and that the 1-hour algorithms were also tested in patients with renal dysfunction and in the elderly, meaning in patients above 70 years. So we can say that the 1-hour algorithm is very safe and effective, including the elderly and those patients with renal dysfunction. So here's the central table of the new non-NSTE-ACS guidelines that were recently published. And here the guidelines provide all these specific cutoff combinations for rule out, including the 1-hour change, and for rule in, including the 1-hour change. And you can see the specific cutoff combinations for the 0-1-hour algorithm, but as an alternative, the cutoffs for a 0-2-hour algorithm. And here you can see the specific cutoff combinations that are recommended for the clinical use of the ortho-VITROS assay. Down here, this is work in progress. We still have to define the optimal cutoff combinations for the ortho-VITROS 2-hour algorithm. So what is the medical value of these rapid rule-in and rule-out algorithms? First of all, and I think this is really the most important point, there is a medical value for our patients. And this is because now we have a management decision when using the 1-hour algorithm within 2 hours in about 75% of patients. So why within 2 hours? Because in most institutions, the turnaround time of the troponin assay is about 1 hour. So we will get back the results of the 1-hour sampling after 2 hours after ED presentation. So after 2 hours, we can say in about 75% of patients if we can either rule out or rule in acute myocardial infarction. It significantly reduces the time of anxiety and uncertainty in our patients, because remember, 10 years ago, patients had to wait for 6 hours, at least in the emergency department. And now we have a decision already 2 hours after ED presentation. And finally, we have a rule out opportunity in about 50% of patients within 2 hours, which is very safe by using the 1-hour algorithm. Just remember the number I've shown you before, like an NPV of 99.8%, sometimes in some studies up to 100%. So it's very safe to apply in a real world setting. Then there is a medical value for us, or for me as a physician working in the emergency department, because now we can initiate treatment earlier. We have the diagnosis of an acute myocardial infarction much earlier, and we can transfer the patient to the cath lab or to the intensive care unit. And finally, we have an improved early risk stratification by using high sensitivity assays and the rapid triage algorithms. And then finally, there is a medical value for our healthcare system, because we can save money when using the 1-hour algorithm, for example, by significantly reducing overcrowding in our emergency department. the median duration of patient stay in the emergency department is significantly reduced when using the 1 hour algorithm compared to the 3 hour algorithm, and of course, if comparing to the 0.6 hour algorithm. And finally, we have an improved allocation of limited healthcare resources in our emergency departments. So just as a short sum up, how to make cardiologists happy. So I'm a cardiologist in training, and I think I've shown you so far that the use of high sensitivity cardiac troponin assays improves the rule-in of an acute MI, and it improves the rule-out of an acute myocardial infarction. It is very important to highlight that we should only use high sensitivity cardiac troponin in the right context. So we should only measure cardiac troponin concentrations in patients with a suspected acute coronary syndrome. We shouldn't use it as a screening tool, and we shouldn't measure cardiac troponin concentrations in patients presenting with sepsis, for example, because we know the cardiac troponin concentrations will be elevated in these conditions. And finally, we should use cardiac troponin embedded in an algorithm. So it's recommended by the European Society of Cardiology, for example, embedded in the 1 hour algorithm, the 1 hour 2 hour algorithm, but there are also different algorithms available. And of course, the use of this algorithm should be supported by the local ED physicians, by the cardiologists, and by the laboratorians. So let's come to the last part of my presentation, the exciting data that we have regarding the clinical validation of the orthoclinical VITROS assay. So this is actually the work behind the current guideline recommendations and how we derived and validated the assay specific cutoff concentrations. So in cooperation with Orthoclinical Diagnostics, we were working on the clinical validation of the new high sensitivity cardiac troponin I VITROS assay. What we did is we used patients that have been enrolled in our large APACE chest pain trial. The APACE trial is an international multi-center study enrolling patients at 12 different sites in 5 European countries, presenting to the emergency department with acute chest pain. We then enroll these patients or sign an informed consent, and we take additional blood samples to then retrospectively measure cardiac troponin concentrations measured by different high sensitivity assays. So we used a subset of about 1,400 patients with available baseline concentration of high sensitivity cardiac troponin I VITROS. For our analysis, we excluded patients who had a STEMI at presentation, because again, remember, the 1 hour algorithms should only be applied to patients with a suspected non-STEMI. We had a few patients in whom a final adjudication was not possible. We had patients presenting later than 12 hours after chest pain onset, and we had patients with missing baseline concentrations of high sensitivity cardiac troponin T and I, architect. So we excluded those patients because we wanted to directly compare the performance of the new VITROS assay against the two best validated cardiac troponin assays. So for the primary analysis, we had 1,231 patients available. We then further excluded 192 patients because these patients did not have available 1 hour concentrations. So finally, for the secondary analysis, for the derivation and validation of the 1 hour algorithm, we had about 1,000 patients. They were randomly assigned by a 1-to-1 randomization into a derivation cohort and into an internal validation cohort. So what we did next, we just had a look how the high sensitivity cardiac troponin I VITROS concentrations were at presentation according to the 5 different gold standard diagnoses that we have in the chest pain trial. So we have a gold standard diagnosis, which is acute myocardial infarction. We have one which is unstable angina, a cardiac, not coronary cause of the chest pain, a non-cardiac cause in patients with an unknown chest pain. And what you can see is that high sensitivity cardiac troponin I VITROS concentrations were significantly higher in those patients with an acute myocardial infarction. We then had a look at the diagnostic accuracy of the new high sensitivity cardiac troponin I VITROS assay, which is here depicted by the red line. So what you can see are two different receiver operating characteristic curves, and you see the corresponding area under the curve. So again, in red, the VITROS assay, in blue, the troponin T-ACS assay, and in black, the troponin I Architect assay. And what you can see is that the area under the curve in all patients eligible for the primary analysis was 0.95, which was at least comparable to the area under the curve provided by the ACS assay and the area under the curve provided by the Architect assay. In another analysis, we had a look at those patients presenting early, which is a very important subpopulation in these trials. And here we had 472 patients who presented within 3 hours after chest pain onset. And again, you can see that the new VITROS assay has a very high area under the curve of 0.96, again, at least comparable to troponin T-ACS and even higher as compared to troponin I Architect. So very high diagnostic accuracy of this novel high sensitivity assay at presentation. So the next step was then to derive and validate the assay-specific 01 algorithm. And therefore, we had to predefine the negative predictive value and the positive predictive value that we want to target. So the target NPV was above 99.5% for the rule out of a non-STEMI, and the positive predictive value was at least 70% for rule in. So these were then the optimal cutoffs. And then we had the derivation and validation sample of 519 and 520 patients. And we had a look at the performance in the validation sample, and we assessed the safety and the overall efficacy. And here are the results. So in the derivation cohort, we defined the following optimal cutoff concentration that reached the target NPV for rule out and the target PPV for rule in. So using the VITROS 1 hour algorithm allows us to rule out 51% of patients in the derivation cohort if you use either a very low cutoff concentration at presentation of less than 1 nanogram per liter, but again, only in those patients with a chest pain onset of more than 3 hours ago, or alternatively, if patients have an initial concentration below 2 nanograms per liter and a delta 1 hour change below 1 nanograms per liter. So again, half of patients ruled out with a negative predictive value of 99.6% and a sensitivity of 98.5%. So only one patient with a non-STEMI was falsely ruled out. On the other hand, we found that an optimal cutoff for direct rule-in is equal or above 40 nanograms per liter, or a 1 hour change of equal above 4 nanograms per liter. 15% of patients were ruled in with a PPV of 75.3% and a specificity of 95.8%. And 34% of patients remained in the so-called observed zone. So we had derived these specific cutoffs, and we applied this novel 1 hour algorithm to our internal validation cohort. And we found that now 53% of patients were ruled out with a negative predictive value and a sensitivity of 100%, which means that no patient with a non-STEMI was missed by the 1 hour algorithm. On the other hand, 14% were ruled out with a positive predictive value of 73% and a specificity of nearly 96%. And 1/3 of patients classified as observed would then need a further diagnostic work. So next to the current 2020 NSTE-ACS guidelines, there is a companion document that was also published, and there is one question in that document, question 12, which interestingly focuses on the clinical use of the VITROS assay. So just let me introduce this case to you. So it's a 60-year-old patient with a prior history of coronary artery disease presenting to the emergency department with right-sided thoracic chest pain. And the last episode started 5 hours prior to hospital admission and is still ongoing at ED presentation. The patient is stable, the physical examination is normal, and also by the 12-lead ECG, the physicians were able to rule out a STEMI. So then blood was taken, and the initial VITROS concentration was in the normal range, 0.7 nanograms per liter. The limit of detection of this assay is 0.39, so very, 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 very low. And the upper limit of normal is 11 nanograms per liter. So it was really in the normal range, very, very low normal range. So the intern in the emergency department asked you as a cardiology consultant if the single very low high sensitivity VITROS concentration allows the rule out of a non-STEMI. And as I've just shown you, the answer is yes, because the patient presented more than 3 hours ago. The troponin concentration is really in the low normal range, so below 1 nanograms per liter. And this was the cutoff for direct rule out in those patients presenting with a chest pain that started more than 3 hours ago. And the negative predictive value for rule out of non-STEMI is, according to our data, above 99.5%. Most of these patients then can be treated as outpatients. So important to highlight that the VITROS 1-hour algorithm allows also the direct rule out of patients with very low troponin concentrations at presentation. In our work, we also assessed all-cause mortality of those patients triaged by the 1-hour algorithm. So what you can see is in green, those patients ruled out. In yellow, those patients classified as observed, and then patients in red who were ruled in by the 1-hour algorithm. So the all-cause mortality 30-day after initial presentation was not, the survival was 99.8% in those patients who had been ruled out. It was 99.7% in observed patients and 98% in those patients ruled in. And then after 2 years of follow-up, the survival rate of ruled out patients was 98.7% and significantly higher compared to those patients in the observed zone with a survival rate of 91.5% and significantly higher as compared to those patients who had been ruled in with a survival rate of 86.9%. So again, a very safe approach also regarding the long-term outcome in patients presenting with chest pain to the emergency department. So let me sum up the findings that I've just presented regarding the VITROS assay. So when it comes to the clinical validation, I've shown you that the VITROS assay has at least a similar performance than the established high sensitivity assays, the Roche and the Abbott assay. When it comes to the 1-hour algorithm, I've demonstrated that we found a very high safety with a sensitivity and a negative predictive value of 100% for rule out of non-STEMI in the validation cohort, and also a very high accuracy for the rule in with a very high specificity, 96%, a PPV of 73%, and an overall efficacy of 65%, which means that by applying the 1-hour algorithm, after 2 hours, we are able to rule in or rule out a non-STEMI in more than 65% of all patients. The prognostic information, we found excellent high, short, and long-term survival rates with very low major adverse cardiac events in those patients ruled out. And what we need next is a prospective validation of the VITROS 1-hour algorithm. So what to expect? We are currently working on the prospective validation of this 1-hour algorithm in an additional data set of about 2,000 patients. We are working on the derivation and validation of an assay-specific 0-2-hour algorithm as recommended by the ESC Guidelines that then can be used as an alternative to the 1-hour algorithm. And finally, we are working on those patients in the observed zone, and we're working to derive specific cutoff combinations using the VITROS assay for these patients who then optimally will allow us to further rule in patients or finally rule out patients, and to decrease the size of the observed zone. Of course, there are challenges to overcome. The first challenge that we are facing is that many institutions worldwide are still using old contemporary cardiac troponin assays. So please start to use a high sensitivity assay. It will really help you and it will really help your patients. By doing this, by implementing a high sensitivity assay, one really has to understand the assay. We have to understand what the 99th centile is and where it fits in the reporting of lab results. Then, and this is, I think, very important point, is the fact that we need an interdisciplinary approach if we would like to implement a high sensitivity assay and a new algorithm such as the 2-hour or 1-hour algorithm. Because there are always questions, for example, when to call the cardiologist for all patients in the observed zone, for patients with elevated cardiac troponin concentrations above the 99th centile, or only for those patients in the rule-in zone. Then I would like to encourage you to use the 1-hour algorithm. It's really important, and we still have to work on the question what to do in the observed zone. But there are strategies and there are recommendations by the guidelines. Perform the 3-hour measurement, perform the cardiac workup by echo, by stress testing, maybe imaging. And then also a very central point is the education. We need repetitive education for all our colleagues, for ourselves. We need education of the ED staff, of the laboratorians, and of course also education of the cardiology staff. So thank you very much for your attention, and I'm very happy to answer your questions.
Thank you very much, Dr. Boardinghouse, for this nice and clear presentation. It is indeed extremely interesting to hear how you did overcome a few challenges as well and use at best the potential of hs-Troponin. So I have a few questions from the audience, and the first being, from your experience, what is the clinical significance of values which are below the 99th percentile in general?
Yeah, that's a very important question. So I think we really have to differentiate the 99th centile from the very low cutoff concentrations. The 99th centile, per definition, as stated in the universal definition of myocardial infarction, is assay specific, and it's important to see whether myocardial injury is present. So if we have cardiac troponin concentrations above the 99th centile, that indicates the presence of myocardial injury. But we know that the 99th centile is not optimal at all for the rule out of an acute myocardial infarction because it is way too high. So for the rule out of an acute myocardial infarction, we really have to go towards the low concentrations. So as I've presented for the VITROS assay, down to 1 nanogram per liter, 2 nanograms per liter, but for other assays, it's the same. So the cutoff combinations, the very low cutoff combinations for rule out are important, and the 99th centile is optimal and recommended for the detection of myocardial injury, but not for the rule out or rule in of an acute myocardial infarction.
Thank you very much. And I have another question, which is more on the application of our troponin test, or generally speaking about troponin assays. So do you have any recommendation on successful education strategies, but also on how long it may take to implement, to move from a contemporary troponin or sensitive troponin to a high sensitive troponin, from your experience?
Yeah, that's also a very important question. So we went through this process actually like 7 to 8 years ago, And so we had like weekly meetings in the emergency department with the ED staff, but also with the colleagues from the laboratory, just to educate everyone what it means by now using a high sensitivity assay. Because of course we will now have more elevated cardiac troponin concentrations, and everyone has to be aware what that means. It means that we have more patients in whom we detect myocardial injury, whether it is chronic myocardial injury or if it is an acute condition such as an acute myocardial infarction. So I think it will take a few months just to get used to it, to use it in daily clinical practice. But once it is implemented, I absolutely believe that it really helps the patients either for rule in or regarding rule out of an acute condition such as acute myocardial infarction.
Okay, and well, there is a very nice, you described very well the different algorithms, the 03, 01, 02. So which criteria should a hospital use when deciding between going for a 01 or a 02 hour algorithm? Which kind of criteria should be taken into account?
Yeah, I think it really depends on the preferences, and it really depends on the infrastructure. So here in Basel, for example, we have a well-structured, well-organized ED, and all the nurses are well-trained, and they know that they have to take troponin concentrations at presentation and after 1 hour. So if it's possible in your institution, if you have the infrastructure, that you have enough personnel, which is then well-trained, to take the samples at 0 and 1 hour, that would be optimal. If you say it's too crowded, we do not have enough personnel to guarantee that the 1 hour concentrations can be taken on time around the 1 hour window, then the 0-2 hour algorithm is a perfect alternative, because it just gives you some more time in the ED to perform the second blood draw. But just let me clarify what 0-1 hour and 0-2 hour means. It means it refers to the timing of the sampling. It does not mean that when using the 1 hour algorithm that you need to have the result back immediately. So if the turnaround time, if in your institution is 1 hour, it's also possible to use the 1 hour algorithm, because you just take the blood at 1 hour and you just take the blood at presentation, and you will have the 1 hour concentration reported at 2 hours, and maybe the first concentration reported after taking the 1 hour blood sample. So after 2 hours, you have both concentrations. Then you can have a look if there is a significant change, and you can still use the 1 hour algorithm. But finally, both approaches are well validated in thousands of patients, and we have data that the 1 hour algorithm as well as the 2 hour algorithm works very well, and are both very safe approaches to use in daily clinical practice.
Thank you very much. So there is another question from the audience. Are you expecting to establish both simple cutoff or delta values for the patients that are in the so-called observed zone?
Yeah. So the patients in the observed zone are really the tricky ones, because what we see in daily clinical practice, these patients are the very old patients, patients with terminal kidney failure, patients with valvular heart disease, patients with chronic heart failure. So often patients with chronic myocardial injury, with chronic mildly elevated cardiac troponin concentrations. So still, we are working on deriving and validating cutoff combinations, for example, for rule-in for the observed patients. Because, for example, if we have patients with chronic heart failure, they might have troponin concentrations around 50 nanograms per liter all the time over the years. And then, of course, we can have a look whether there is a significant change. So whether there is an acute condition on top of the chronic myocardial injury, and if we have a specific cutoff, we can then rule in these patients and detect that there's also an acute condition going on. But this is really tricky. We really need to have a closer look at these patients. But for sure, we will come up with recommendations regarding cutoffs for the observed zone patients.
Dr. Berdinghaus, you are so knowledgeable that you trigger many questions from the audience. So there's another one I wish you could answer as well, which is, could kidney disease affect the results of hs-Troponin in general, but particularly VITROS hs-Troponin or other assays, according to your experience? And apart from kidney disease, chronic kidney disease, would also hemolyzed samples affect cardiac troponin measures in your experience?
Yeah. So if I've told you before, we validated the performance of the 1-hour algorithms also in patients with impaired kidney function. I think it's still a matter of ongoing debate why exactly troponin concentrations are elevated chronically in patients with kidney failure. Some say that cardiac troponin concentrations are less like released by the kidneys because of an impaired kidney function. But I think we should also think about that patients with kidney failure and terminal kidney failure do also very often have cardiac conditions like heart failure. So I think impaired kidney function very often is also an indicator for the presence of heart disease, which then might be the cause of elevated cardiac troponin concentrations. So yes, in patients with kidney failure, we have elevated cardiac troponin concentrations. However, we have evidence that the rule out in these patients is still possible. If there is no significant change, it means it's chronic elevation, it's not an acute MI going on. And on the other hand, if there is a significant increase or decrease on top of the chronically elevated cardiac troponin concentrations, we can also rule in an acute MI in patients with kidney failure. But this needs more research to really understand the pathophysiological mechanisms why cardiac troponin concentrations are elevated in nearly all patients with kidney failure.
Thank you. And we are almost at the end, but I cannot avoid asking a question related to the COVID pandemic that we are facing worldwide. So within this context, in which cases would you recommend using hs-Troponin tests to help preventing serious cardiac damage often associated with the COVID disease?
Yeah, that's of course a very, very interesting question that affects us all. I'm not an expert in that field. We're currently running a study, so fortunately I will have a specific answer to that question soon. And we measure troponin concentrations in all patients presenting with possible COVID-19. So I mean, if patients have a severe pneumonia due to the COVID-19 infection, they might present with a sepsis, with an infection. And we know that in all kinds of infections, cardiac troponin concentrations are elevated. And the higher the cardiac troponin concentration, the higher the risk of mortality. That is what we know regarding cardiac troponin concentrations in different conditions. So the higher the concentration, the worse the outcome. But if that necessarily means that we have to measure cardiac troponin concentrations in all these patients, I think it's a matter of ongoing debate. I'm not really clear about that. And then, of course, there are like the cases, COVID-19 patients with very heavy myocarditis, really affecting the heart. Of course, these patients do have elevated cardiac troponin concentrations, as all patients with a severe myocarditis. So real recommendations, I do not have one. It is an indicator for worse outcome, but if we should measure troponin concentrations in all COVID-19 patients, I'm not sure about that.
Okay, yes, I fully understand this position, your position, indeed. Okay, so let me thank you on behalf of Ortho Clinical Diagnostic for this great presentation, Dr. Birdinghouse. It has been a pleasure to learn from you and to have your experience shared. Thank you to all the participants, and thank you for today's participation. Bye. Hello, have we finished?